want to welcome commissioners and members of the public. This is another remote-only commission meeting. Given that this is a remote-only meeting, the additional ground rules apply as typical for these meetings now. I'll begin the meeting with a roll call of commissioners. During the meeting, I'll ask that people speaking identify themselves before speaking. That way, commissioners and members of the public will know who's talking and have the same knowledge as if the meeting were being held at our usual facility on Reisterstown Road. We're using Zoom meeting today. All commissioners are unmuted and may speak. The public and most staff should self-mute and may not speak unless recognized by me. Due to the possibility of background noise, I do ask that commissioners and others mute their microphones when they are not speaking. And I am getting some background noise right now. I think there are several commissioners and staff who are unmuted right now. If they could please mute. For this meeting and at future remote-only meetings, we will post documents that will be acted on or discussed at least a day in advance so that members of the public will have time to download them before the meeting begins. We'll continue to provide advance notice of how to register for and dial into the meeting by posting that information on the Commission website homepage and on our various social media channels. I will now call the roll. Commissioner Akintate. Bim, are you there? I did not hear you, and I thought I saw you previously.
I'm scrolling through now. I'm not seeing him right now.
He was on the lunch meeting, not meeting, just get together. Commissioner Bandari, I see you.
Yeah.
Commissioner Boyer, I just saw you. Commissioner Boyle.
Here.
Commissioner Brumbaugh.
Here.
Commissioner Dorden.
Here.
Commissioner McCarthy. Jason, no. Commissioner Metz.
Here.
Commissioner O'Connor.
Here.
Commissioner Reimer.
Here.
Commissioner Sargent. Got it. Commissioner Sargent.
I'm here.
Commissioner Thomas. Dr. Thomas, I saw you.
I do see him. He just looks like he's muted right now.
Got it. We will wait to call him present until he acknowledges. And Commissioner Wang, Marcus.
Commissioner Wang's here.
Excellent. All right. Have any other commissioners joined the call?
Yeah, this is Commissioner O'Grady. You just sort of skipped calling my name.
They didn't include you on my list.
Okay.
Yeah. Did you RSVP? I
thought so.
Welcome.
Thank you.
Good to have you.
Thank you.
Included in your packets are copies of the minutes from the March 18th public meeting of the commission that took place by video conference. I'll entertain a motion to approve the minutes of the March 18th commission meeting.
So moved.
That was Commissioner Metz.
I'll second Commissioner Sargent.
Commissioner Sargent, all in favor?
Aye.
Aye.
Any opposed? The minutes have passed. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Does the executive director have any updates? Ben? I'm hearing background noise and I'm not hearing Ben.
I'm here now, Dr. Pollack.
There you go. Okay.
So a couple notes, just a couple facts on the state's pandemic response. I think everyone knows that we're going through something of another mini surge, although the population that's affected tends to be younger. than in previous waves, reflecting the fact that folks over 65 are largely vaccinated. That's reflected in the deaths really haven't increased markedly, nor have COVID hospitalizations increased as significantly as the latest wave would indicate based on past experience. I think it does show the strength of the vaccine effort, but a lot more needs to be done. Maryland is now reached a point where about a third of the adult population has received at least one shot. It's impressive for those over 65, where 80% have received one, and fully 2/3 of the population over 65 has either received the 1-dose Johnson & Johnson full vaccine or the 2-dose Moderna or Pfizer treatment. So I think there's a lot to be happy about, but the challenges remain. Commissioners have asked me, what more we could do. I think one of the things that I think I want to emphasize is that our role is to very diligently continue to fill our mission. There is a significant commitment on the part of the state for the pandemic. Recent tabulations indicate that upwards of 11,000 people are working in one area or another of the pandemic response, from screening, contact tracing, vaccine delivery, administration. So there's a significant contribution on the part of state government to this response. And although there may be this area or that area that could benefit from some additional work, I think our role is to continue our very important mission with our colleagues at the Department of Health, HSCRC, and residents across the state. To that end, on the 25th of March, we did learn from CMMI, the Centers for Medicare and Medicaid Innovation, that they had approved what's called the state's integrated health improvement plan, which really focuses on an approach, a three-legged stool, if you will, that focuses on improving hospital quality through the reduction in avoidable admissions and readmissions, care transformation initiatives, of which our work on the Maryland Primary Care Initiative is but one example, and then a population health framework, which focuses on initially 3 population health activities: diabetes, reduction in opioid deaths and better management of opioid addiction, and maternal and child health. That's just getting underway. There are work groups and management teams forming currently. And in the next month, I will be asking our colleagues in the department to present an overview of the program to the healthcare commissioners so that you're aware and are fully briefed on how you individually can contribute to some of these efforts. Clearly, healthcare, our work on reporting on avoidable admissions and readmissions, as some of you are aware through our quality reporting initiatives, are important aspects of strategy 1 or domain 1. Our work on care transformation initiatives. We continue to work on primary care, but are looking at other specialty efforts as well. And our work on population health are all roles where the Healthcare Commission can play a role. I will share with you the document that describes the overall initiative after the meeting today, and would be happy to talk more with the commissioners individually. And you can expect a briefing next month on the overall strategy. You'll hear today a major portion of the meeting on what happened during the legislative session. It went surprisingly well, except for the fact that the sine die celebrations were, as I understand it, non-existent. I think we all can forego that, given from the standpoint of the Healthcare Commission, what we hoped to see passed did get passed. What we largely were unenthusiastic about or opposed didn't get passed. So everything considered, it was, I think, quite a successful legislative session. There were broad reforms also passed in terms of medical debt, policing, education, and there were important initiatives that you'll hear from Tracy later on today about that we will be taking on this session. But I want to take this moment to thank the commissioners for your participation in the legislative sessions that went on early in the legislative this legislative session. That your input was invaluable, and your continuing support and guidance as we move through these important responsibilities we have will be key to the success of the commission. I also want to thank the legislative team that was headed by Tracy, but also included Sade and Dee, and was aided by all the center directors and our attorneys, who everyone jumped in and contributed as we moved through the cycle. And I think the commission's reputation in the legislature was only enhanced by the work of everyone this past year. So I want to thank everyone for their work. I'll be happy to take any questions.
Ben, this is just a comment. This is Commissioner Thomas. I just want to thank the commission for that letter of support for the Shirley Nathan Pulliam Health Equity Act. It passed. You have no idea how excited I am. And, you know, it had been up before when Senator Pulliam was in office, sometimes with no funding. And then you get, Marcia Boyle knows about this, the unfunded mandates, you know about that. But this time it passed with resources. So very, very excited. And I can't but help think that the supportive letter from the commission was added value. Thank you very much.
Thank you, Commissioner. And the staff worked with the sponsors. It's important to note that a major focus of the legislature this session was on health disparities, and they put the framework in place. Now the rest of us have to step up.
Glad we were able to help with that. Ben, I want to challenge something you said in the beginning with regard to the current spike and the burden on hospitals. Today's numbers show about 1,200 hospitalized patients attached to a positivity rate of 5.78%. If we go back to late November, which was sort of a prior time when we were at about 1,200 hospitalizations statewide, the positivity rate 10 days before that, which sort of drives the hospitalization rate, was about 6.1%. So we're about 0.3% difference. So the rate of hospitalization doesn't necessarily seem to be creeping down at the same rate. It's definitely true that the population is younger that's affected at this point, which tells me that if we didn't have that elderly population over 65 vaccinated at a high level, we will be looking at something much, much worse right now than what we're seeing. But the hospitalization level right now is becoming burdensome in the state, and that's really been more true over the past 2 or 3 days, I would say, than it had been before. We can't let our guard down now. The social distancing efforts need to stay that we have in place need to stay in place, as well as the ongoing vaccination efforts.
Good points.
Other questions for Ben? Teresa, I understand you have an update for us.
Yeah, the update is that we recently went live with our healthcare quality consumer website. So we're real excited about that. And we like to encourage everyone to take a look at it if you can, or when you can. We think there's a lot of good information, and we are definitely open to suggestions for improvements.
Great. Before we consider action items today, I want to remind commissioners that if they wish to recuse themselves on any action item, they should inform me. Since this is a remote meeting and a commissioner cannot move to a small conference room, the commissioners who are recused should remain silent and mute their computers or phones. Moving on to agenda item number 3 will be our legislative update, and Tracy DeShields, Director of Policy Development, will provide an update on the just completed legislative session. She'll provide an overview regarding the outcome of bills of particular interest to the Commission. Tracy, if you're ready, please proceed.
Great, thank you. Good afternoon, Mr. Chair and Commissioners. This is my last update. So this is a wrap up of the legislative session. On Monday this week at midnight, the General Assembly wrapped up its 442nd legislative session. Amazing. And as been mentioned, the legislature basically put in a lot of safety protocols, doing everything virtually, very limited. Only the legislature, when they were on the floor, were they in person. And remarkably, and I think to their amazement, made it through the 90 days of the legislative session with 0 related COVID issues or delays, which if you think about it is pretty amazing. I know that they had to undergo rigorous testing. So anytime they were in person, they had to get tested. So they had all those things working for them. And from what I understand, is every day seemed like it was going to be their last. So they kind of approached everything with a little bit more urgency than maybe they normally would have. Next slide, please. So, well, we have 0 days left in the session. Yay, all of us. As I have mentioned before, the number of bills introduced were well over 3,000 bills, and between the House and the Senate. And this is kind of always blows people's minds, is that out of 3,000 bills, 3,336 bills introduced, only 837 bills were passed. And this is, it amazes everyone, the number of bills that are actually introduced versus the number of bills that they actually pass. So probably just a little more than a quarter. MHCC, we tracked 160 bills during the session. We did weigh in directly on 20 bills, either supporting with amendments, opposed, providing information on legislation. So with that, as unusual a legislative session as it was, it was a very ambitious session for the legislature. As Ben mentioned, just some general things. They passed police reform, and out of that, the governor vetoed 3. There were 5 police reform bills introduced. The governor vetoed 3 of those bills. The legislature did veto overrides on those 3 that were vetoed. And so those bills are going into effect. They expanded voting rights, dealt with some COVID issues related to education and learning, passed an economic stimulus package, did criminal reform, particularly around juvenile justice, They dealt with broadband issues across the state, particularly in Western and Maryland and in urban areas where broadband is lacking. And of course, they did a lot in healthcare as usual, but a lot of the healthcare issues were around things around inequity. So I think it was a very productive, and I think probably a pretty, I don't know how to, I think in a long time, probably a legislative session where a lot of what happened has impact on everybody in some manner or other. So with that, and oh, look, MHCC, no interim work. Sorry, just joking. We have a lot of work to do. Anyway, during this session, there were areas of focus for the commission were predominantly 3 areas: health information exchange, telehealth, and health disparities, which is amazing because usually you can't really define things so cleanly in 3 different areas. Next slide, please. Next slide, please. Great. So we had our bill, MHCC's bill. Our bill got introduced, and this is really amazing. We were actually very fortunate. Our bill came in pretty late within the legislative session, and we got it moved out of rules from the House and then out of rules in the Senate, and our pass, which is a great, which is just amazing for us. And within that, House Bill 1375, dealing with electronic health information sharing and disclosure. So our bill really sets up a one-stop shop opt-out so that consumers can opt out of having their health information shared by a health information exchange. I'm going to ask, I don't know, I think Ben or David, if you guys would just like to provide a little bit of information related to our bill, that would be great, especially around our compromise on the bill would be nice if you could add your perspective to that.
Sure. I'll take this one and let David do the hard one that's coming up. The House Bill 1375, I'll say it as I said, told the Finance Committee and Health and Government Operations Committee, is a complementary bill to another bill that we called the CRISP bill, House Bill 1022. That bill broadened the information that could flow through the health information exchange to include information passed through by nursing homes and what are called electronic health clearinghouses or electronic health networks that process administrative claims. That bill enabled that information to flow through. What the pandemic demonstrated to us was that there were significant gaps in the information that CRISP was able to supply for public health. And 1022 actually provides some additional enhancements and with regulations developed by the Healthcare Commission, authority for CRISP to receive that information. In parallel with that, 1375 recognized that there were we have a hot mic, I think, on the part of someone. So if you could mute, that'd be helpful. 1375 really provides a framework for consumers who are reluctant about sharing their information to opt out through a consent registry that would be established and maintained by the state designated health information exchange, CRISP, that then would be queried by the other 10 electronic or health information exchanges in the state. They include entities like Epic, which provides electronic EHR systems to the likes of Hopkins and University and Anne Arundel Medical Center, as well as Cerner and other local health information exchanges. So it achieves what many consumers think they have already, which was when they opt out of CRISP today, they are opting fully out of health information exchange. That's not so. To fully opt out, a consumer today would have to go to the other 10 health information exchanges and individually opt out. Once this consent registry is in place, a patient can opt out fully out of all information exchanges, or continue to have information shared through them all. But this is really not, we see this as just the first step. What we see as ultimately the solution is a much more graduated or granular information exchange, where consumers can perhaps selectively opt out of one exchange or another, or selectively opt out of certain types of information exchange while permitting others. So for example, a patient could opt out of information pertaining to behavioral health treatments, but not opt out of other medical care, or perhaps opt out of treatment for substance abuse, but allow other information to continue. We're fairly far away from that currently, but this really moves us into that first step. There was an area of contention that we resolved, and that related to the definition of health information exchange. We sought to broaden that. Health insurance carriers did raise some concerns. So we left that definitional construct as it is in the statute today, but agreed through the uncodified language to come back with a definition, a broader definition of health information exchange that will cover, of course, the current construct, but the evolving nature of health information exchanges that really represents the way that they are evolving, which was not as a brick and mortar entities, but rather as processes, as part of software products such as EHRs. So it's a very exciting step in an agency that really promotes information exchange. It may seem odd that we would be pushing something that would allow consumers to have more oversight over information. But we think that's really the key point, that as we broaden information exchange, we do move towards giving consumers a greater ability to control the flow of information going forward. It's a major step forward. And we appreciated the support of both the leadership in the House and in the Senate in allowing this late introduced bill to flow through rules. Delegate Ariana Kelly was extremely effective in putting forward a legislator's perspective on why this was a consumer-friendly bill, and therefore deemed consideration late in the legislative session.
Great, thank you. And then also, I think as Ben mentioned, we will be working over the interim with stakeholders to come up with a recommendation for the statutory definition of an HIE. Next slide, please. Okay, so this is the CRISP bill, House Bill 1022. That bill passed, and it requires nursing homes to report to CRISP, submit certain clinical information around that. Also, MHCC is to make a report back to the governor and the General Assembly around the availability of funding and the sustainability of the technical infrastructure required to implement the bill. So in it, we have a couple of things. So Chris will be required to accept clinical information from nursing homes. Nursing homes have to provide that information. MHCC, I believe, Ben, that we have to, I don't know if we have to modify our regs or not, but anyway, in the bill, it does say that our regulation, we have to provide regulatory oversight as it relates to the information and the redisclosure, in particular, financial information and data, patient data, I believe that that information has to be, we have to make sure our regs cover that and what can and cannot be disclosed, redisclosed, if you will, as it relates to nursing home patients. So this bill actually made it through quite well and passed well before the end of the legislative session, which was great. Next slide, please. Telehealth. Telehealth was another major area for the legislature this year. There were about 5 or 6 bills introduced. 3 of the bills introduced were cross-filed. 2 were standalone bills. And as everyone is aware, this was an issue that the Lieutenant Governor felt very strongly about and actually put in his own bill on telehealth. This bill, the bill that ended up passing, which was great, the House and the Senate, I think a lot of work was done predominantly in the House on the telehealth bills. The House, I think, was able to get agreement and consolidate the different bills that were introduced on the House side into one bill, which turns out to be the final bill, House Bill 123. And then the same occurred on the Senate. The Senate was probably a little easier because a lot of the work was done on the House side. And then legislators were able to compromise a lot of the things that were brought up. For example, Medicaid and requiring Medicaid to cover certain issues, or particular private insurers to cover certain things under telehealth, were all sort of merged into House Bill 123 and Senate Bill 3 together. This bill was signed on Tuesday, excuse me, by the governor, along with 62 other bills that were introduced this legislative session. So next slide, please. And I'm going to ask David, because one of the things, MHCC, there are a number of reports that the legislature is requiring to be completed by the end of 2022. Not only for MHCC, but also HSCRC has a report they're required to do, as well as the Insurance Administration. They have a report, and the department has a report related to Medicaid and coverage of telehealth. So David, I'm going to ask David to comment on the study. I will just make this particular comment. There was a lot of work that was done in subcommittees, and I think every time we got a copy of the bill, the study got bigger. But anyway, David, you want to just talk a little bit about the study and your thoughts?
Sure. Good afternoon, commissioners, Mr. Chairman. So just to sort of take us back a step, think of this bill as sort of locking down what existed when the state of emergency was declared around the use of telehealth. There was a lot of relaxation in terms of policies on reimbursement and on policies that sort of dictated the use of telehealth, that essentially became the norm through the pandemic. And what this bill is doing is locking them down at least through June 30th of 2023. And in advance of the MHCC's recommendations, as Tracy noted, in a report that's due by or sooner than December 1st of 2022. And there's a study with lots of components to it that came out of the subcommittee work and the interest of stakeholders to really give the legislature some idea on how to move forward with legislation around advancing telehealth through, again, holding some of the relaxations in place or making changes to it. So I'll talk just briefly, highlight what I'll call the grouping of 7 for the moment. The first area of the study is an analysis of the impact of use of telehealth on disparities in access to healthcare services, including primary care and behavioral health services, and whether different communities and patient populations have differences in uptake rates. Area 1. Area 2, a study on the alignment of telehealth with new care delivery models. Area 3, an assessment on the efficiency and effectiveness of telehealth and in-person visits. And you may recall there was a lot of discussion about the use of audio only. So that's an element of the study that we'll be focusing on as it relates to the in-person visits. The next area, category 4, an assessment of patient awareness and satisfaction with telehealth coverage. So this is to some extent is a survey of sorts of consumers to get their opinions. The next area is another survey, but it's looking at provider satisfaction on the efficiency and effectiveness of telehealth and in-person visits. And again, where we're looking at telehealth, we bring in the audio only aspect of it as well. The next category, next to the last one, inclusion of clinical hospital facility fees in reimbursement for hospital provided telehealth. And Tracy mentioned that the HSCRC has a role in producing an element of the study that will be included in the final report. And this is the area where we'll look to the HSCRC to complete that aspect of it. And then the next area is review the appropriateness of the use of telehealth to satisfy network adequacy standards. And this, again, Tracy mentioned the Maryland Insurance Administration. The section 2 will be a supplement in the final report provided by the MIA. So it's a very interesting bill. It has a lot of work to it. The time limit is very short for completing all the work. I think we're up to the challenge. Staff is excited about digging in and getting started. And we'll keep the commission updated as the work progresses during the next 8 to 10 months. So Tracy, that concludes my aspect. Happy to answer any questions on Senate Bill 3 and HB 123.
Are there any questions from the commissioners?
Yeah, this is Chip. Chip Jordan. I wanted to ask David a quick question in regards to that last slide where number 2, a study of the alignment of telehealth with new models of care. Are there new models of care that you're going to study, or is that whatever happens in the next 2 years?
So that's a great question.
What does that really spell out, David?
So think of it this way: new models of care delivery. The Maryland Primary Care Program is a new model, considered a new model of care delivery.
Okay.
Hospitals have, you could say an ACO. You could say any of the programs under CMMI that they've rolled out that impact providers, where there's risks and there's changes in requirements on care. These would all be essentially fall under the umbrella of new models of care delivery.
Just seems awfully open-ended. You could study things forever.
Now, I think your point is well taken, but I think the way we've sort of viewed it is within the scope of care delivery models that have either been introduced or already in play, if you will.
Thank you.
You bet.
David,
Are there any other questions? Oh, good.
Hello, Dr. Bhandari.
Yes, sir. Number 5, is currently this clinic hospital fees included? I remember Dr. Pollack mentioned one time it should not be. What is the status until this reporting is done? Is it included or not right now?
So the HSCRC issued a letter back in April and defined it. And I apologize, I don't recall the particulars of it. It's actually out of reach. But let me get back to you with that, unless Ben has the recollection off the top of his mind.
So the hospital facility fees cannot be included. Currently, that's consistent with the federal response as well, where telehealth standards were relaxed at the federal level, but facility fees could not be charged. What's a little different in Maryland is that because hospitals are on global budgets, the question about what's the status of the revenue that would have been earned through the facility fees had they been charged. HSCRC opted to allow hospitals to retain those. I think one of the outputs of this study that they'll play a role in is what's the approach long term.
Yeah, and the information came out on February 15th from the Health Services Cost Review Commission, and it states, to Ben's point, that regulated facilities will not be allowed to bill a clinic fee when a practitioner can bill a professional fee.
Thank you.
Sure.
Are there any further questions? Next slide, please. Okay, so the other area that the legislature really focused on were health disparities. And in general, they really focused on disparities as a whole. And I think from the viewpoint of the legislature, given the bills and sort of the conversations had around those bills, disparities were considered to be even broader than health, or health disparities was considered to be very broad, including social economic issues, just the wide gamut of issues. And a lot of this, I think, was brought about just by the breadth and depth of the pandemic, and just the things that have occurred in the last year and a half related to the pandemic, and maybe not so related to the pandemic, but has focused more attention as a result of the fact that people are home and just, I think, just more engaged at this point.
May I add something?
Sure.
If I could, this is Commissioner Thomas. I think that, that pandemic definitely shined a bright light, but I'm thinking back to some of the groundwork that helped us in Maryland move quickly. And that was some of that legislation I talk about that sometimes has unfunded mandates. The Health and All Policy Work Group that did a major report submitted to the governor and was accepted by the governor. And many counties, Montgomery County and Prince George's, established health and all policy work groups in their local counties. When the COVID hit, they used that infrastructure to now bring the COVID message in. So I thought it was very interesting that we helped break down some of the silos early on, bringing people around the table, around these chronic diseases, around health disparities. And then COVID hit, and they were already at the right table. They had the right people at the table. I'm just hoping that as the surge wanes and we think we're back to whatever the new normal is going to be,
right,
we don't abandon these very methods that have brought people to a table that otherwise would have been siloed and fragmented. And I think the community is expecting us not to abandon them after the so-called surge has passed, these underlying conditions that they've been suffering with are serious. And the very methods we've deployed around COVID can actually help them with the chronic diseases that we've documented so well. Thank you.
Wow, that's great. I think you captured it great. And I think that's sort of the thinking with the legislature. The bills that I'm going to just talk about, while they're separate bills, they are all interconnected. And this is something that I brought up during our senior staff meeting. Like if you think about transparency and then the overlays on a transparency to show different things, this is how these bills are. House Bill 28, Senate Bill 5, House Bill 78, Senate Bill 52, and House Bill 309 and Senate Bill 565. They're all really dealing with the same sort of areas of the law, but there are amending them in different ways in different aspects of it, but they're all interconnected. The bill, House Bill 28, Senate Bill 5, deals with requiring implicit bias training for healthcare professionals. And if I do remember vaguely that this came up one other time, but this time, I mean, it's really a doubling down. People do have to demonstrate that they've taken it. And I think many people will find that they have no problem. I think a lot of healthcare professionals do take such trainings anyway. And it also requires the Office of Minority Health, along with MHCC, again, to revitalize, if you will, or bring back into view the healthcare disparities policy report card, and race and ethnicity will be added to it, as well as some information around healthcare professionals, their race and ethnicity. And also they included dementia. They wanted to include dementia as well in there around, I guess, morbidity and mortality rates around dementia as well. So, so that's one thing that we're doing. And then next slide, please. House Bill 78, this is the one that passed, that is named for Shirley Nathan Pulliam now, the Maryland Commission on Health Equity. So, and this commission is comprised of every cabinet secretary and or their designee for this commission, which is amazing. And then, believe it or not, the Insurance Administration and the Maryland Benefit Exchange came in and asked to be amended into the bill, which you really don't have a lot of that. Usually people will try to get out of a bill, but they actually want it to be part of it. So I think that is pretty telling that people find value or are seeing value here. Also to be noted around this bill, CRISP, the state designated health required to also participate on the Maryland Commission on Health Equity, as well as provide data information, especially around ethnicity and race as it relates to health disparities. So the broad, the mission or the goal of the commission is to provide advice to the governor, to the legislature on racial, ethnic, cultural, social, economic disparities, and how to solve those, to come up with recommendations on how we address those in our society. And I think that that's what tremendous value. The department, and I believe it probably will occur through the Office of Minority Health, is required to staff this commission. And then there's going to be an advisory committee set up on data collection. That advisory committee will be set up with the help of CRISP. MHCC, along with the HSCRC, is to provide information, data to the commission. And so I do, this is just my personal opinion, I do think that MHCC should be part of the advisory committee on data, because that's very important when you're defining what data you want and what you need. You need to have those that are going to be providing you data at the table so that you know what's available, what you can get and what you can't get. The other thing is MHCC will need to, and I don't, this is probably already laid out in statute and regs already, approve what data is collected by CRISP around this area of racial and ethnic information. So,
Ms. Tracy?
Yes.
May I add?
Sure.
Commissioner Thomas here. I can't, I wish we were all together because you'd see how excited I am right now as she's reading this. But I want you to know that here's what put us in the front page of the Washington Post and then picked up on wire services all over the country. That the preamble to this legislation had the word addressing racism.
Yes.
And the controversy was around taking that out. That was the compromise. Yes. It eventually got taken out. But that was the story that went around this country. Okay. Not that it was not the fact that we are one of the first in the nation to pass a bill like this, but the controversy over taking out the word racism. And that was before the reckoning that we're all now seeing on the newspapers and then TV. So just know that underneath this is a recognition. And now we know, Dr. Pollack and all my friends out there, CDC Director Walensky announced 2 days ago that racism is a public health issue. And all the science that had already documented and proved that over the past 10 years is just as valid once she made that declaration as it was before she made that declaration. But now, hopefully, the barriers are gone and we can embrace this as public health scientists, as policymakers, and not run from it or be afraid of it. I think the country is calling on us to really address this. And in my personal opinion, it is the health space, Ben. It is the space we're in that is the solution space, not criminal justice. And I hope justice is served, but it is here in health, medicine, public health, wellness, that we can actually come together and find real solutions to this issue. So thank you so very, very much.
And on that note, I would say I did listen to some of the floor debate around the preamble. And for a while, if you really weren't paying attention, you would have, what are they arguing about? Like one side is, because of the speeches and the angst. So, and then finally someone got up and said, well, I'm offended that you used the word racism or racist in the preamble. And I think that people were like, oh, which I'm kind of surprised they actually took out, but that it was a very contentious, I would say contentious a little bit, floor debate, but it was on both sides in the House and the Senate. And I have to really say that the Speaker of the House, I listen more to the Speaker of the House than on the Senate side, but both with those debates and some of the things that were said, I think they handled it amazingly appropriately. And I couldn't agree with you more that I do think the sense of solving issues and problems in this area is in the right space, and it's health. So it's I think there's that reality, and that's why, you know, the focus during this legislative session was on that. And just so that everyone is aware, there was another bill that passed called the Commission on Equity. And this bill directly deals with, again, disparities, but much more beyond health, even though the health is going to be beyond that. But these two move the chart, because the other commission is really charged with coming up with resources and things like that. So I'll be sending out probably like a memo on some of the other things, pieces of legislation, and that will be one of the things that I'll include in that. And that'll go out to the commissioners and staff as well.
And just let me say, the commissioner, for Commissioner Pollack, I don't know, you know, and all the medical people here, if you may be members of AMA and you may get JAMA and New England Journal, but I'm going to say something about the JAMA, Journal of American Medical Association, and the podcast that blew up, and it also went all over the country, where then the editors were commenting that healthcare physicians could not be racist. There's no such thing as institutional racism. And again, all over the country, the editors have resigned. I mean, this is a true reckoning in our field and in our profession. And I think that the kind of the concrete has really been broken up, and we have an opportunity to find a new steady state, one that recognizes that we are indeed a solution space for addressing these issues, and that we can disagree without being disagreeable and actually move the needle. I hope there's a nice big press release about this to tell this positive story about what's happening in the state of Maryland. Thank you.
Great. Next slide, please. And then this bill, House Bill 309, Senate Bill 565. This one was really interesting because I wasn't sure the Senate bill was going to actually move. They just waited a long time to move it. But I think, again, there were some amendments to the bill that were being worked out, and the work was being done on the Senate side, but in collaboration with, I mean, on the House side, in collaboration with the Senate. So it was just a matter of timing with regard to the bills. But this one, you know, really requires the director of the Office of Minority Health and Health Disparities, again, really to work with MHCC and the department as a whole, and to look at health data that includes race and ethnicity information, and identify changes and how that information, you can move the needle to make health improvements across the board. It also authorizes OMHHD to request certain health data, including race and ethnicity. Within 30 days, they have to provide it to somebody else if somebody requests it. And so this requires that they do a report each year to the General Assembly. And then also for this year, they do have to come up with a plan. They do have to work with MHCC and MDH to come up with a plan on the collection of data information. So again, another important bill. Some of this may seem redundant, but it really isn't. They are amending various areas within the bill. This particular bill does require the governor to include 1.8 million in the budget for the Office of Minority Health. I think the feeling is that it's probably been a neglected child within the health department, and the legislature is making the point it should not be. So I think that this is a good, I think this is a great year when we are looking at issues around disparities in general. Next slide, please. So in addition to legislation, one of the big things the legislature does is pass the budget. For us, the budget this year was really non-controversial. Our appropriation was $35 million. Part of that, $12.3 million goes to the trauma fund, $3.6 million to really shock trauma. And Ben, would you like to make comment around the budget, in particular, I guess, related to the trauma fund and some issues there?
Thank you, Tracy. Don't be misled by the 35 million. The 35 million in special fund. Our operating budget is about 17.5 million. The remainder is trauma fund and other pass-through funding for park and other programs. So I'll just make that broad statement first. The commission staff did make a couple inquiries, I guess, given we recognize that as a result of the significant federal commitment to struggles, budgetary struggles, that this would be an opportune time to see if we could request the administration to replace the $8 million that had been taken from the trauma fund in 2019 as it was needed to fund Medicaid physician fee adjustments. We haven't received any commitment, but we're hopeful that some of those funds would be replaced, and we'll continue to work with the leadership in the administration to see what opportunities there are, given the stimulus bill provides some flexibility in what existing funding gaps can be supplanted by federal dollars. That's all I really can say at this point.
Tracy, you're muted.
Sorry, thank you. Additionally, also within the budget, there's usually requirements for reports. And so there is budget language that requires the HSCRC and the MHCC to do a report on the efficacy of the hospital at home model and to submit that report by December 1st, 2021. So next slide, please. So there were just a few other bills that we were following. One in particular, that House Bill 936. This bill had been introduced several times before. It never passed. And essentially, in a word, it just would require a notice to public officials when there is a closing of a hospital or freestanding facility or partial closure to them within a certain time frame. That happens anyway. They want that time frame to be moved up so that they're aware of it, I guess, ahead of any public hearings or anything of that nature. And as noted here, MHCC, we are looking at implementing some of the requirements by enhancing our website, putting that notice on, and I think there are just further discussions about how best to do that moving forward. Next slide, please. So House Bill 565,
Excuse me, Tracy, one question on that past slide. This Commissioner
sure.
O'Connor. On the last sentence there, you have one conversion of a hospital to an FMF is possible. Do you have any idea which hospital you're referring to?
Ben, can you help me out on that one? You're muted.
Commissioner O'Connor, Bon Secours.
Oh, okay.
Okay, thanks, Ben.
Next slide. Great. So House Bill 565 deals with medical debt and protection. This one, this was a bill also that had been introduced several times before. This time it had a lot of momentum. Again, I think the minds were much more focused and got it done. The hours spent on the House side, along with the Senate, was amazing on this bill in subcommittee. So we weren't really part of this bill, but we were following the discussion here. Essentially, we just have we just have one area to look at. It's related to CRISP, and the question came up as to whether or not they could be used to help determine whether or not a patient or patients meet the financial eligibility goal to receive some sort of financial assistance as it relates to medical debt. I will say this, one of the areas of controversy, and I think might actually be revisited by the legislature, came up around the composition of consumer advisory committees that hospitals are required to have. There was a lot of discussion about that. No one knew really how they were comprised, how they're utilized, that sort of thing. So that wouldn't surprise me if somehow it comes back up or a report about their composition comes up or something like that. So it was pretty lively discussion, very interesting discussion and bill hearing on this particular bill. Okay, next slide, please. Okay, so another bill that we actually weighed in on initially is Senate Bill 837, dealing with advanced directive planning, advanced care planning, and advanced directives. So this particular bill would have sets up a process, if you will. The goal is to try to encourage people to do advanced directives. And it actually is trying to promote electronic advanced directives and a place to store them online so that a physician or whatever could have access to them. Family members could have access to that information in one place. So we did, on the Senate side, we initially submitted a letter of information explaining exactly what is going on in the world of advanced directives and how things are actually sort of playing out, which is these advanced directives are basically kept with electronic medical records and are predominantly found there. And then on the House side, the bill passed intact on the Senate side and crossed over to the House. We upped it to a letter of opposition for the same reason that what's going on generally in the marketplace or in the world of advanced directives. This particular bill isn't going in that direction. It's actually, things have moved away from that. With that, I'm going to ask David or Ben if they could kind of weigh in on some of the what's happening in that world.
I'm going to just jump in here. David's the expert, but given the wanting to move ahead with the meeting, we'll just say that we think we can fashion some compromise working with the payers and hospitals that provides more options for consumers.
Great. Next slide. Great. So this is a bill we were not following at all, but we're in it. This bill creates a commission on trauma-informed care. Commission dealing with training around that. This particular bill sets up the commission, defines what the commission will do. The issue around trauma-informed care has been around a long time. This bill was basically moved by the governor's office on crime and children, youth, and families. And it will require us to be involved in that with regard to the development of the program called ACEs Aware. And what it stands for is Adverse Childhood Experiences. And so the bill takes effect July 1st, 2021. Next slide, please. And last, these are just a few bills. We have no roles here, but however, they are bills of interest for us. In the assisted living world, it would require regulations be put in place around training for assisted living unit training with regard to dementia. And then long-term care planning requires information around long-term care planning be published and posted on the website. So we will probably be involved in some of that just because of the information that we do put on our website around quality of care. And then with regard to the issue that came up prior to the beginning of session about the transfer of nursing homes ownership. And this last bill, House Bill 674, just requires that there be a full survey done 3 months after transfer of a facility to a new owner. And then the Office of Healthcare Quality would then go back in again at 120 days unannounced to do a follow-up survey. So with that, that would conclude sort of my overview. And if there are any questions, happy to answer them. Like I said, I'll be sending out a memo on the various pieces of legislation and some other bills that are pertinent for the commission and staff to know about. Thank you.
Thank you, Tracy. Any other comments or questions for Tracy?
I'll just say that was one of the best legislative sessions I've had in my entire time on this commission. So I know we don't always control those things, but what an opportunity to see the needle really move. Thank you, commissioners, so very, very much.
This Commissioner McIntyre. I'll also just say a big congratulations. I'm relatively new and the bar is set super high. So I guess this is like my new expectation. But congratulations once again.
Thank you. Moving on to more mundane affairs. The agenda item number 4 is an action item, certificate of need for Adventist Healthcare Shady Grove Medical Center, a capital expenditure of $180 million, exceeding the capital expenditure threshold, and a change in bed capacity. Adventist Healthcare filed a CON application seeking to build a 6th-floor patient tower and renovate a section of the existing hospital to convert all of its medical surgical rooms to private rooms, to modernize and expand its emergency department, ICU, and observation unit, and to improve clinical workflow and operational efficiency. Program manager and CON analyst Bill Chan will present the staff recommendation. Bill, please proceed.
Thank you, Chairman Pollack, and good afternoon, commissioners. Hope you can hear me. Adventist Healthcare Shady Grove Medical Center proposes to add a 150,000 square foot 6-story patient care tower and renovate almost 26,000 square feet of the existing 40-year-old hospital. The project will not add any new services and that it is not intended to increase the number of beds the facility will operate. The patient tower is designed to modernize the existing facilities and services. The objectives for this project are to create more private patient rooms, modernize and expand its emergency department, ICU, and observation units, and add space to improve both clinical workflow and operational efficiency. The total project cost is estimated at just over $180 million. The hospital will fund the project with $154 million in tax-exempt municipal bonds, about $10 million in cash, and $16 million in philanthropic donations. The applicant expects to complete the project in 2 phases, scheduled over 66 months, with the projected completion in August 2026. With regard to the need for the project, the hospital identifies the following problems: the use of semi-private patient rooms that create challenges to patients and staff regarding infection control and patient privacy, the lack of space in ICU rooms to accommodate modern technology and equipment, an aging emergency department that lacks the size and space to meet the American College of Emergency Physicians guidelines, the space and the growing population and volumes of patient visits seeking emergency services, and that the current layout and lack of adjacencies cause issues with regard to patient flow and staff efficiencies. While the hospital will not increase the number of med-surg beds that it currently operates, the project will add physical capacity in the form of 74 private rooms on the patient tower's 3rd, 4th, and 5th floors. As those beds come online, Shady Grove will convert 20 existing semi-private rooms to private rooms. The hospital expects to renovate and convert the remaining undersized and dated inpatient rooms into alternative uses in future projects. Initially, they would be repurposed or remain vacant, used as temporary patient rooms as other spaces are renovated and/or remain available for potential surge capacity. Because of this significant increase in physical bed capacity, staff recommends a condition limiting their use for inpatient purposes. Staff also recommends a condition on a potential approval by the commission based on the construction cost of hospital space standard. Staff concluded that the proposed project is about 23% higher than the benchmark cost established using the MVS or Marshall Evaluation Service methodology. This methodology uses an amalgamation of cost information for the new construction of a good quality hospital that includes current industry cost experience in Maryland. Under this standard, applicants can propose a design that is over and above this basic design, but makes clear that the hospital cannot expect reimbursement to cover those excess costs. The purpose of this standard is to include reasonable costs and exclude any excess costs from any future rate increase submitted by the hospital to cover the cost of the project. The project will not have any material impact on other existing healthcare providers, as no new capacity or services are being added, nor will it cost physicians who practice at other hospitals to change referral patterns. The applicant does not seek an increase to its GBR to pay for this project, though it reserves the right to do so in the future, so it is not expected to have an adverse impact on system costs. The project appears to be financially feasible and viable as its volume and financial projections align with historical trends. The applicant projects a continuing positive bottom line, and HSCRC responded to staff's inquiry with the opinion that the hospital's gross revenue and expense projections were reasonable and conservative. That Shady Grove has the resources to finance and sustain the project, and that the project is financially feasible. The staff recommends approval of the project based on its conclusion that the proposed project complies with the applicable state health plan standards, demonstrates the need for the project, its cost effectiveness, and its viability. The patient tower will not have an adverse impact on the existing providers or the healthcare delivery system, will improve access for patients, and create opportunities for more efficient operation of the hospital. Staff recommends that any CON awarded by the commission should include the 2 conditions stated in the staff report. The first, that Shady Grove Medical Center shall identify bed capacity it will retain in operational status, the bed capacity it will repurpose but retain as physical bed capacity, and the physical bed capacity it will eliminate. And the second condition, to exclude $21 million, $226,090 from any future change to the financing of this project, involving adjustments in rates set by the Health Services Cost Review Commission, reflecting the excess cost defined by the MVS methodology. Before we go any further, I'd like to pause and introduce several individuals representing the hospital on the line. The leader and spokesman for this group is Andrew Nicholas, who is the Deputy General Counsel for Adventist Healthcare, who will introduce his colleagues.
Hi, good afternoon. Thank you, Bill, for the introduction. Good afternoon, commissioners. Thank you very much for having us here and for your time and consideration of our application. I do want to start by thanking Bill and Kevin McDonald and their whole team and the staff at the commission for all their hard work in reviewing our application and putting together this recommendation. It was there's a lot of work that went into it, and we appreciate the collaboration and in getting to this point. This is a very important and exciting proposal for Shady Grove Medical Center, as it will ultimately benefit, we believe, our patients and their experience in getting care at our facility. So we do have a robust group of individuals here representing Shady Grove and Adventist Healthcare, and I'd just like to introduce them to you quickly. We have Dan Cochran, President of Shady Grove Medical Center. We have Mike Lukens, the Chief Financial Officer of Shady Grove Medical Center. We also have Kristen Pulio, a Senior Vice President and Chief Revenue Officer for Adventist Healthcare. We have Maureen Diamond, Vice President of Financial Services for Adventist Healthcare. We have Jeff Morgan, Vice President and Chief Facilities and Property Management Officer. Martha Velez, Associate Vice President of Reimbursement and Strategic Analytics. We have Linda Berman, our Certificate of Need Consultant. And then we also have Dan Sullivan, who's the president of the Sullivan Consulting Group, who helped put together a lot of the needs analysis for our application. And we have Howard Solins, our counsel with Baker Donaldson. And so that's our group. Thank you again for your time, and we look forward to your review.
Thank you.
Yes, that ends my presentation.
Thank you, Mr. Nicholas, and thank you, Bill. Do I have a motion to approve the application of the Adventist
Chairman,
Healthcare?
I make that motion.
Okay, let me thank you, Commissioner Dorton. Let me finish the motion just so we're clear, though. Approve the motion for the Adventist Healthcare Shady Grove Medical Center for a certificate of need, including the 2 recommendations from the staff. Commissioner Dorton, that's still your motion?
Absolutely.
Thank you. Do I have a second?
Second.
Second, yeah.
I'll take Commissioner Boyle's second because I could see her name. The comments or questions from the commissioners? Hearing no discussion, I'll call a vote. All in favor?
Aye.
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 Any opposed? Any abstentions? Very good. Congratulations. You have your certificate of need with the 2 conditions. I think the lack of discussion is not a reflection of a lack of interest. It's a reflection of a very complete application and an outstanding job as typical by staff in reviewing these things and again, bringing them to us completely polished. So we're very grateful for that, and good luck.
Thank you very much.
Thank you. Moving on to agenda item number 5, annual assessment of the state health plan, priorities and timeline for review and revision of state health plan regulations. So the next item on the agenda is the annual assessment of the commission's priorities for the state health plan. Maryland law requires that the commission annually assess the plan and determine priorities among the various chapters needing review and revision, and develop a timeline for that review and revision. Paul Parker, Director of the Center for Healthcare Facilities Planning and Development, will provide staff's recommendation for consideration and action by the commission. This is an action item as well. Paul, please proceed.
Thank you, Dr. Pollack, members of the commission. Good afternoon. So as the chairman mentioned, this is a statutory requirement which was established fairly recently, I believe 2019. So obviously, informally, we have been looking at our priorities for state health plan development over the years. but now we have this formal requirement under the statute. Next slide, please. So this is just a bullet point presentation on what Maryland statute says about the state health plan, and I've highlighted the task before us today. Annually or upon petition, assess each chapter. The state health plan is a large body of regulation that we divide into chapter by project categories, determine the chapters that need review and revision, and establish priorities and timelines for review and revision of chapters. Next slide, please. So a little background here. In 2018, the Commission studied how to modernize the Certificate of Need program. And obviously, Certificate of Need application decisions are based on the state health plan. So that report did include a number of recommendations about the state health plan. We want to limit the number of standards going forward. And actually, this has been something that we've been implementing for the last 6 or 7 years, certainly since I've been in a position to oversee all of the state health plan regulations. When you look at the 6 chapters of regulation that we've updated over that period, there has been a significant reduction in the number of project review standards in each chapter. We're always looking to simplify standards, but we did include this in our modernization report for emphasis. We're always trying to, whenever possible, have very clear and measurable standards. There's always a bit of tension between that and having some flexibility in certain areas, but simplification is something that I stress in our work on the state health plan. And the criteria, currently there are 6 criteria that we've adopted in our procedural regulations. So these create the real kind of framework for making project review decisions. And the first of those is compliance with state health plan standards. But then the other 5 are need, viability of the project, impact of the project, the track record of the applicant, and the availability of more cost-effective alternatives to the project being proposed. So we've de-emphasized that to some extent based on this modernization report. So going forward, there'll be less emphasis on that particular criteria. We'll also probably see some changes in these. We will no doubt see changes in this framework when the procedural regulations are updated. Next slide, please. So this is the current state of the state health plan. And you can see here that we have one set of regulations that's currently under revision. Those are the psychiatric, they're now called the acute psychiatric services regulations, and those have been adopted as proposed regulations. And I think we had news today that means that we'll be able to publish those for formal review and comment prior to adoption as final regulations very soon. And then we also have made a lot of progress in a general surgical services chapter update. This is not an old chapter like the psych services. It's been significantly updated twice in the past few years. But because of legislative changes that we largely supported in 2019 and 2020, this is a chapter that we needed to update, and it's a frequently used chapter. Next. So this is one that we showed you last year when we first went through this exercise. It's been updated to include the projects that we've reviewed in the past year, completed reviews on. And so you have a full 10 years of experience on just CON applications. I mentioned that because we do have other types of project reviews that we do that are not CON applications, but this one focuses on CON applications because I think that's the appropriate thing to look at when we're looking at how frequently we use these regulations. And what you see here is that over half of our project reviews really fall under 3 project categories: general surgical services, nursing home services, and general hospice services. The hospice services number is probably a little deceptive because we had a flurry of hospice projects kind of in the earlier part of this 10-year period. And I think with the update of that plan chapter in 2013, and then actually not putting it into real implementation until 2016, that's a number that's gone down considerably. Next slide, please. So this is just to give you an idea of what our current pipeline is. It's been reduced substantially in the past year and a half. We had a period of probably 3 or 4 years before that where we actually saw a lot of growth, a lot of applications came in, and perhaps not surprisingly, we haven't had that many come in recently. So these are active applications that are docketed and both docketed and undocketed, and then valid letters of intent, which could result in projects in the future. Next slide, please. So I'm starting here with taking acute psychiatric services off the table, since we have adopted those as proposed regulations, and we anticipate probably being able to get to final regulations within the next few months. And so our #1 priority now is general hospital services. That was #2 a year ago. And this is a chapter that is used, I call it medium frequency use. It's moderately outdated, but for the most part, with the exception of a couple of standards, it's still, pretty serviceable. We want to improve the alignment of that with the total cost of care payment model that came into effect a couple of years ago. So the focus of the upgrade will be in that area. Again, scaling back the number of standards, and particular areas that we've noted for improvement because of our use of these standards are the charity care standard, the shelf space standard, and the cost and space related standards. Those will be a focus for this update. Next slide. So this is actually the area where we have actually made a change in the priority order since last year. I've moved up, I'm recommending moving up the alcoholism and drug abuse ICF services chapter into a high priority status. And then the other 2, and these were also considered high priority last year, general hospice services and home health agency services. These are not old chapters of regulation, but we've had a chance to kind of use the home health agency services chapter, and that experience has certainly led me to believe that we've got some significant streamlining that we can do in that area. And I'd like to make it a more open, figure out ways to make it a more open chapter of regulation, where getting to thresholds where people can actually propose expansion of services or perhaps even introduction of new agencies is a bit easier and more flexible. And our general hospice services chapter, again, not that old, only really began implementing it in 2016. But the design of this plan, in my view, needs a lot of work, because it really is almost kind of produced kind of a one-off set of reviews, which we've now finished, and the opportunities for any changes in the hospice service delivery system are very limited by this plan. So we definitely want to try to make some progress in the coming year on updating both of these chapters. Next slide. So the chapters that I put into the medium priority, one of these is a chapter we've done a lot of work on in the past year. And
Yep, Steve.
I ask people to please mute your phones.
No, it's fine. It's like a boring board meeting that I listen in on every month.
Lavon, do you have an ability to mute Ms. Fetterman?
Yeah, I'm looking for it now.
She's right down there. I don't know if it's here, but.
Shoot. I don't see it.
She's, yeah, I find her on my screen.
Yeah, I've got everybody up on mine. I see. I got it. Okay, it's done.
Thanks.
Thanks, Luan. So general surgical services, we do anticipate getting that to the commission soon as a proposed regulation. Again, the reason why this is a medium priority is because it's really not a critical update. We're not really changing the basic framework of the plan. We're primarily updating it to reflect the recent statutory changes of the past 2 years. But we think that's pretty important because it has been a chapter that historically has gotten a lot of use, and it's not good when you've got regulations that are out of date because people tend to look at regulations before they look at the law. The other medium priority chapters are the FMF chapter. We've had that for a few years now, and we've gotten experience in using it. So I think just as a general position, we should kind of take a look at that, not too far off in the future, to see how that's functioning. The residential treatment services are what I call a rump section with the update of the psychiatric hospital services chapter, which again is called acute psychiatric services. We do have a small section of the residential treatment, the small section of that chapter that addresses residential treatment center services, but it is obsolete. It really does not reflect current conditions in the RTC services environment. And I think we probably will not see a lot of projects. This is a low frequency use chapter, but I think we do need to update this. Rehabilitation hospital services, again, because of its age, it deserves to be in the medium priority section. Next slide, please. And then our low priority neonatal intensive care. Basically, this plan is fine. There is another updated set of perinatal service system standards that's been adopted by MDH, and those need to be incorporated by reference in the plan. The obstetric services chapter has been used one time. It's been in existence since 2002. Interestingly, it looks like we may have to use it again soon, because we do have a letter of intent. Organ transplant services updated fairly recently, obviously low frequency use. Cardiac surgery and PCI services, same. And then we have another rump section now. When we updated our nursing home standards in 2019, we had a small section of chronic hospital services standards that remain in place. Again, we do not see these type of projects coming in, and the idea that we would ever look at establishing a new chronic hospital seems very remote at this time. Next slide, please. So the timeline here, I think we still have a possibility. We've got May and June left in the current fiscal year, so I think it might be possible we could get those acute psych services finalized in June. If not, I think definitely by July. And then in the coming fiscal year, which starts July 1, I think I'm very confident that our general surgical services chapter will be updated. And I think we would like to see, if possible, if we can get the other three high priority chapters of acute care hospital services, general hospice, and home health agency services looked at and updated. And then further out, alcoholism, drug abuse, ICF services. I'll confess that I really was hoping that we would not need to update this, because it has been our policy position that this is a project category that should be removed from the scope of CON regulation, but we've not been successful so far, and we have had projects that need processing. So Again, I suggesting that we now consider this a high priority, but it's also one that I think from the standpoint of the plan itself, it's not that bad of a plan despite its age. And then I've talked about FMFs, RTC services, and rehab hospital services as something that we don't need to take up in the very short term. So I think that is my last slide, if I'm not mistaken.
Before I move to questions, comments, do I have a motion to approve the annual assessment of the state health plan priorities and timeline for review and revision of state health plan regulations as proposed in this deck by Paul?
So moved.
Commissioner Bandari. I have Commissioner Bandari and the second, Commissioner Metz.
That's fine. Yes, thank you.
Okay, good. Discussion. So I'll go. Paul, talk about the aggressiveness of 4 in a year. Although I get it's really like 3.5 because general surgical services is largely forward. Do we have the bandwidth to do these other 3 in this coming year? Because I'm concerned that we're going to set some expectations when we throw this out there.
Yeah, I think the one area that we have improved on, and I think I mentioned this a year ago in talking about this, we did have a shortage of staff. And what we've been able to do in the past year is add 2 additional staff to the Division of Acute Care Policy and Planning, which is ably led by Eileen Fleck. And so now that she's got a full staff to work with, actually for the first time since she took over that division, I think that even with what she's got on her plate now, and short term, she still has quite a bit of work on the Certificate of Ongoing Performance Reviews for PCI, but acute care hospital services will be her priority, getting that update started. And I think it's reasonable if she can keep that level of staffing in place to get that one done. The general hospice services and home health agency services are Linda Cole's long-term care policy and planning. And there, I think they're more limited in terms of the amount of work that will be required. They're both, as I noted in my presentation, fairly recently established plan chapters. So they're not obsolete, but I think what we now realize after fairly comprehensive updates in recent years is that we still haven't gotten to the point that we want to get with these plans, which is an ability to kind of unfreeze those service delivery systems and actually make it easier for hospice, general hospices, and home health agencies who are good performers, because that's an emphasis in both of these areas, to expand into areas where it makes sense to have more consumer choices. And I think that's really kind of the overarching emphasis in updating both of those plans. And I think we have sufficient staff in that division that we should be able to get that done.
Excellent. So I think the good news is also that the temperature in Annapolis around these is not as great as it was around acute psychiatric services. Number one, and number two, the fact that I don't hear Eileen jumping up and down and screaming that you've promised too much is probably a good sign that she agrees with that assessment of our ability to get all this done. So the other comments from commissioners? Hearing none, I have a motion and a second. All in favor?
Aye.
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 Any opposed? Outstanding. Motion passes. Thank you, Paul.
Thank you.
Thanks to you and your team for great work here. Agenda item number 6, expanding telehealth adoption and ambulatory practices, grant highlights. So Melanie Cavalieri, Chief of the Innovative Care Delivery Division, will present on the findings from the grants regarding expanding telehealth adoption and ambulatory practices that conclude at the end of this month. Last April, Commission staff awarded a grant to 3 state-designated management service organizations. The grant aimed to advance telehealth adoption in small ambulatory practices. Melanie, the floor is yours.
Thank you, and good afternoon, Mr. Chair and Commissioners. Next slide, please. As Dr. Pollack mentioned, in 2020, telehealth became a critical tool to mitigate the spread of COVID-19 and ensure continuity of care. In April of 2020, MHCC made up to $500,000 in grant funding available. The estimated total spend at the conclusion of the grant will be around $350,000. The funding allowed MSOs to tailor telehealth guidance and technical support to meet the unique needs of eligible practices seeking to adopt telehealth. Next slide, please. MSOs worked in collaboration with staff to identify practices for participation in the program. Practices were also identified through medical society and practice referrals and cold calls made by MSOs. Small practices were targeted as they tend to have fewer resources to set up their own systems and workflows to support telehealth. The goal of the grant achieved its goal of 100 practices. MSOs successfully implemented telehealth in 112 practices. Next slide, please. The MSOs qualified for this grant included MedTech, Syndicus, and ZaneNet. MSO services focus on optimizing the use of health IT as a key component in achieving practice transformation, making them well-positioned to support practices with telehealth implementation. Obtaining state designation requires MSOs to meet certain annual benchmarks relating to business operations and privacy and security. Next slide, please. This table shows practice counts by county. Practices were located throughout the state. 61 were primary care and 51 were specialty care. Practice size ranged from 1 to 7 providers, with the average size around 1.5. The grant increased telehealth as an option for 300,000 Marylanders served by these practices. Next slide, please. The grant consisted of 4 milestones. The first milestone was practice readiness, which consisted of the completion of the TRA tool in collaboration with practice staff, development of a plan to address areas of improvement, and consultation on the selection and implementation of a telehealth solution. Milestone 2 was education. MSOs provided practice education on telehealth guidance issued by OCR, CMS, Medicaid, and commercial payers regarding new and existing requirements and temporary waivers during the PHE. Milestone 3 was workflow redesign. MSOs developed a workflow redesign matrix in consultation with practice staff consisting of re-engineered workflows to support telehealth. Milestone 4 was training. The MSOs trained practice staff on using telehealth technology and implementing the practice-approved workflow. Next slide, please. So MSOs were responsible for coordinating outreach efforts for practice recruitment. A shared outreach log was maintained by MSOs detailing the status of practice engagement. More than 2,000 practices were identified as potentially eligible to participate in the program, of which 223 expressed interest. Urgency for virtual visits at the beginning of the PHE resulted in many practices implementing telehealth prior to being contacted by an MSO. Approximately 50% of the practices that expressed interest in the program worked with an MSO. Next slide, please. A total of 93 practices completed an online questionnaire and attestation qualifying for the $500 incentive payment. The questionnaire inquired about practices' experience with telehealth implementation, satisfaction with MSO services, and plans to continue using telehealth. Next slide. Over 90% of practices expressed satisfaction with MSO services. Next slide. 97% of practices plan to continue offering telehealth beyond the PHE. Next slide. That's the end of my presentation. There's additional information in the appendix that you may find useful. I'm happy to answer any questions. Levon, do you mind just scrolling through the appendix so they can see what's in there?
I don't add the appendix to the main presentation.
Oh, okay.
Everybody received the appendix electronically and by email and by mail. Comments?
Just a quick question. This is Commissioner Thomas. I'm obviously so excited to see we were at the forefront of telehealth before it became really, really fashionable in the pandemic. And we had evidence under our belt of what works. When you mentioned the $500 incentive, is that the total amount? Say a little bit more about that.
Yeah, so the grant was mostly to fund the support for the MSOs to provide technical support to the practices. The $500 practice incentive was mostly just to offset the time that it would take them to, complete the survey, do the training, implement the telehealth. It really wasn't meant to be a financial support for to purchase a new system. It was not intended towards technology.
Well, I'm actually just impressed that a relatively small amount of an incentive can really accelerate adoption and embracing the methods. Even the grants that they received are not huge grants, and so when we've gotten reports back from the previous grantees, it's very impressive what they're able to deliver on fairly modest resources. This is Commissioner Thomas.
And just to note, Melanie, the practice incentive was paid out when the practice would attest to actually using the technology in care delivery.
Yeah, I just want to point out, having just lived through our transition during the pandemic, a large scale transition of a major large practice to high use of telehealth. The amount of work involved in making sure that from a connectivity standpoint and a privacy standpoint, you're meeting requirements, and then figuring out the integration aspects with the EMR, those are all not trivial. And for a small practice to be able to do it is a really, really big challenge. They don't have the kind of resources that a large multidisciplinary practice does. So this type of grant and this type of support, I think overall, is something we need to consider expanding going forward, or figuring out how to get that type of support to small practices, because otherwise they become irrelevant and becomes impossible to keep up with the multitude of technological advancements that are necessary. There's just not enough margin in those practices to make the kind of investment in that kind of technology that's necessary.
Thank you for that feedback.
Commissioner Pollak, if I can ask you a question, and anyone else who's on the front lines, because a lot of companies are coming up with technology, wearables, all kinds of things, and just use telehealth for our example. As you've mentioned, it is a lift, and I'm curious as to what extent it adds layers of complication and even burden in the midst of the crisis. It's one thing under normal circumstances, but now in the midst of the crisis, if they're starting something new. Or David, if you found that those who had been grantees were able to easily, jump into this in a robust way because they had that early grant, that little pilot grant we had given them, and they worked out some of the bugs that may have been part of adoption. Any insights there on either end?
So I'm happy to speak to the one aspect, and we really targeted practices that would not have been able to adopt the technology and implement the processes were it not for the assistance of an MSO that provide that technical guidance. Dr. Pollak's point can't be emphasized enough that smaller practices, it's not a trivial matter for even larger practices, but smaller practices simply will walk away from it. And during the PHE, the fact that we were able to deploy in more than 100 practices meant that, as Melanie noted, nearly 300,000 consumers had access to their healthcare provider when they might not have otherwise had it. And that was kind of the message we heard from providers. So, that's probably how I would leave the response to that question.
That's a great story at a time when we need great stories. I wish we can get that in the front pages. Thank you.
I think there are two sides to the adoption challenge that we faced, and we've talked a lot about the challenges on the provider end, but there were challenges on the patient end too, and some of it was related to access, and some of it was related to comfort and willingness, right? So the incentive on the patient end during the pandemic was you're going to get to see your doctor without the risk of being exposed to a deadly disease. So that was a big incentive, it turned out. And patients were all of a sudden willing to try this. The second thing that happened during the pandemic that was very, very important was that they waived the federal government waived the requirement that these things be HIPAA compliant, which allowed us to rapidly transition to platforms that were readily available to much greater numbers of patients. So previously, you had to have access to really fancy broadband to be able to connect to these things. Now you can connect to your doctor on your iPhone with video, just like you would your friends. So that doesn't mean that everybody's got access now, but it means that a lot more people had access than did before. So the combination of those two things, I think there are a lot of things that made this thing go light speed during the pandemic, but the combination of those two things really changed the playing field. And to your question as to how far ahead of the game were people who who had benefited from some of these grants pre-pandemic, I would say that they benefited, but the playing field changed so dramatically during the pandemic that everybody else caught up real quick.
And Commissioner Pollack, is it your sense that these whatever relaxation that came in the name of the pandemic will stay in place, or if they start rolling it back, whether it's rolling it back on parity between in-person versus tele, rolling it back on what you just described around using other platforms related to HIPAA compliance and other things, if these things start getting grandfathered out or rolled back, would you see that as, what would you see that? How would you interpret that? So my general response to that kind of a question is that any time that you add more regulation, you make things harder to get done. But that said, I think when they roll back these the relief that was provided, what you're going to find is that during the past year, all of these non-HIPAA compliant platforms that we were able to turn to for ease of access for patients have each recognized that those restrictions were going to go away and have moved toward the development of HIPAA compliant modules. So I think that it would be a very heavy lift to ask CMS to continue to allow people long-term to use non-HIPAA compliant platforms. That just doesn't seem rational to me. And I think that when patients and the public looked at it, they'd have privacy concerns long-term about it. I also think that we will be able to maintain the advances despite the move back toward a HIPAA requirement, because the individual providers have, or the individual providers of the internet connection services have gotten to HIPAA compliance in a lot of different ways. So Doximity, for example, and a bunch of others that are readily available that link the healthcare provider's EMR directly to the patient's cell phone with a click of a button, that don't require the patient to have any special software to download, and allow the patient to just answer like you're answering a call and go about your regular daily business. That technology is going to be readily available in HIPAA compliant form, and it won't require that the declaration of the state of emergency provisions remain in place. Thank you.
All right. Any other questions for Melanie? Great presentation. Great work, Melanie. Thank you.
Thank you, Dr. Paul.
You're still on the floor here. Melanie will now give a presentation on the grant announcement entitled Advancing Practice Transformation in Ambulatory Practices. The grant will fund one or more care transformation organizations to work with primary care and specialty practices to implement changes that will prepare them to participate in a payer's advanced care delivery model. Melanie, please proceed.
Thank you. Next slide, please, Yvonne. So the goals of the grant include preparing practices to deliver high quality care that is efficient while improving health outcomes, laying the foundation for practices to provide team-based, patient-centered care and using health IT efficiently, supporting the broad goals of the total cost of care model by readying practices to participate in advanced care delivery models. So a total of $500,000 in grant funding is available, and the grant may last up to 2 years. It is intended to support approximately 50 practices and between 75 and 100 providers. We anticipate the practices will have 1 to 2 providers. Next slide, please. We believe the grant's needed for many reasons. The reasons include transformation is a cornerstone to healthcare reform and an essential requirement for practices to improve care, achieve better outcomes, reduce costs, improve staff satisfaction, and address social determinants of health. Practices face pressure from payers to move away from fee-for-service to new ACD models. Helping practices keep pace with the evolving landscape is critical to retaining practices in ACD models. CTOs are well positioned to assist practice transformation. CTOs are organizations approved by CMS to assist practices in the Maryland Primary Care Program with transformation efforts. There are currently 24 CTOs. Next slide, please. I will now describe the grant milestones. Next slide. The CTOs will lead the practice recruitment effort. Practices interested in the program must complete an application. Key application areas to determine eligibility are current quality improvement activities such as care management, current patient and family engagement activities like patient and family advisory councils, health IT capabilities, the level of HIE engagement, and the MHCC will select practices based on applicants' overall application score and available funding. Next slide, please. The first milestone is to complete the TCPI practice assessment in collaboration with the practice. The CTOs will then use the results to identify what phases of practice transformation have been completed and guide development of practice-specific training. Assessment categories include the following. Person and family-centered care design helps the practice to tailor care delivery to meet the needs of individual patients as well as the entire patient population. Continuous data-driven quality improvement encourages every person in the practice to innovate and improve. Sustainable business operations provide the infrastructure and capabilities to support positive patient experiences, staff that experience joy in work, and resources for investing in the practice's future. Next slide. The second milestone is to examine existing practice workflows with a focus on resolving bottlenecks and pain points. The CTO will then develop workflows that support coordinated care across the care team and will work collaboratively with practice leadership to implement those new workflows. It is recommended that CTOs use the ONC workflow redesign templates. Next slide. The third milestone is practice training. The CTOs will guide practices through the 7 TCPI change package modules. The modules include Power Packs. Power Packs are designed to address specific, discrete hurdles on the pathway to preparing a clinical practice to adopt an ACD model. Training can be done virtually or in person. Group training sessions are strongly encouraged. Group sessions are capped at 5 practices per session, and key practice staff and a physician champion must participate in each training session. Practices are required to complete a quarterly program assessment questionnaire to report on transformation progress. Next slide. To assist practices that complete the program in finding ACD models that meet their individual needs, A list of names of practices that complete the program will be shared with private payers with ACD models, MedChi, MHA, HSCRC, and posted on MHCC's website. Practices that complete the program will also receive an MHCC Practice Transformation Program Completion Certificate. Next slide. So that's the end of my presentation. There is, again, additional information in the appendix that you might find useful, and I'm happy to answer any questions.
Any questions for Melanie on this program? I have one quick question. So, as you know, I think there's a financial incentive for the CTOs to hit the milestones and work with the practices along the way. But the question becomes whether the financial incentive is enough at that $9,800 maximum per practice, or whether is there a way, as you know, if the CTO is successful in transforming the practice, and the practice moves to a model that includes a CTO and requests that CTO that was involved to be affiliated the following year, there's no guarantee that they'll be assigned to that practice. Is there a way to sort of grease the skids in the first year so that you know that if you're successful with a practice, that as a CTO, you'll be able to tell that practice, yes, you'll be able to work with this particular CTO going forward? Did I make that question clear? I feel like I stumbled around it.
No, you did. You did. I think I understand what you're saying, but not all of these practices would be primary care. Some of them may be specialty practices, and not all of them may qualify for MD-PCP. So I believe that's what you're talking about, right? So if they were successful, if they went into the MD-PCP and they were like, wow, this CTO was so great, I really want to continue to work with them, and how can I make sure that I do that? Right. That may apply to some of them, but I don't know that would apply to all of them. And David, I believe the assignment to CTOs is done by CMS. You can request them. If you do get accepted to the Maryland Primary Care Program, I believe the next step is you request a CTO, but I believe the actual assignment is made by CMS.
Yeah. And I guess I'm not familiar with how often the actual assignment varies from the requested assignment.
Yeah, so anecdotally, it's not often. In fact, it's probably seldom. But I think Dr. Pollack makes an extremely good point. One of the ways we can help characterize this for both practices and for the CTOs that participate is that should you get involved with the Maryland Primary Care Program and there's a great positive relationship, you might consider requesting their support on your application. I think it creates, it does fill sort of a void, it builds relationships. And I think that's a very good suggestion we can bake into this program.
Ben, I think you had a comment.
Yeah, I'm seeing this a little different, that we have started to think about whether a CTO framework is a broader feature of the healthcare system in Maryland than something that is kind of narrowly defined to primary care. This is going to give us a chance to think about that. We've had some conversations with some CTOs that are thinking more broadly of engagement with other providers beyond the health system. And it's consistent with the state integrated health improvement strategy. If we really can prove that CTOs are a feature that can work more broadly than with primary care. Obviously, the incentive in MD-PCP is that there's a funding arrangement with these others. At this point, there is not, but that would be something that I think with HSCRC and the department we'd want to explore with CMS.
Great. Other comments? Other commissioners? Very good. On to agenda item number 9.
Melanie, this is Dr. Bindari. Which specialty practices are in this one? In my opinion, I think this may be more better for the primary care. I don't know how much this incentive is good for the specialty practice.
That might be the reason that you need the grant. Melanie, you want to comment on that?
Dr. Commissioner Thomas says $500, I said, well, it's too much paperwork. I will rather don't take $500 and.
You don't get $500 for this one.
No, the other one was. This is a $9,800, but still it's.
The $9,800 goes to the CTO in this
No,
one,
you don't
not
get
to the
anything.
practice.
You don't get anything.
Melanie, you want to address the question?
David, you looked like you want to answer. Would you like for me to answer?
So you go ahead, I'll follow.
Okay, it's open to any specialty, and I would kind of align this to maybe the practice transformation network efforts that were done in Maryland, and that included many specialties. Again, small practices who needed help working through kind of the beginning stages, and the efforts were successful in getting them to work through the transformation stages. So I do think that this is a good format for specialty practices. Again, the payoff would come at the end when they're able to join an advanced care delivery model that would offer them different revenue choices outside of fee-for-service. David, did you want to expand on that?
That's well put. I think I don't have anything else to add, but that is the value. It's getting through the transformation process when independently you probably wouldn't have been able to do it or do it as well.
Thank you.
Any other comments? Thank you, Melanie. Two great presentations.
Thank you very much.
All right, agenda item number 8, spending and use among Maryland's privately insured 2019 data. So the Healthcare Commission is required through a legislative mandate to report annually on expenditures for privately insured services using the Maryland Medical Care Database, the MCDB. This report examines spending and use among privately insured Maryland residents under the age of 65. Shankar Mehta, Chief of Cost and Analysis in the Center of Analysis and Information Systems, will give us this update. Shankar, the floor is yours.
Thank you, Mr. Chairman. Good afternoon, Commissioners. Thank you for sharing the purpose of my presentation. Can you hear me? Sorry. Okay. All right. Okay. Thank you. I am pleased to present this annual report on behalf of my division with you all today. This report focuses on 2019 NCDB data, which is an important year serving as baseline before the pandemic. However, we want to note that we do have data through end of 2020 and hope to share a COVID-related impact on healthcare cost and spending in future. With having said that, let's dive in to check out the highlights of this report. Next slide, please. Okay, thank you. I would like to put some context to this report before we get into the background. This report serves as an annual checkup on privately insured population to get a feel about healthcare spending and use in Maryland, and then compare it to a national benchmark to gain insights to inform policymaking. It also helps data users to determine the representativeness of MCDB data for research purposes. Each year, Commission staff analyzes the most recent 3 years data in MCDB to report on enrollment trends, population risk, cost, and utilization of healthcare services among members enrolled in private insurance. This report contains data about Maryland residents enrolled in fully insured, self-insured health plans and are under 65 years of age. We excluded self-insured ERISA and Federally Employees Health Benefit, or FEHP in short, members from this report. Due to exclusion of FEHP, we had to recalculate 2017 and 2018 data, which resulted in different growth rate in 2018 than previously reported growth rate in prior year privately insured report. The FEHP HMO population, which was included in last year's report, had a higher age and gender factor compared to the non-FEHP population that was used in this year's report. This lower age and gender factor for the non-FEHP resulted in less expected claims cost per member than if the FEHP HMO plan were included. This exclusion accounted for about 44% or 1.68 million members being excluded from the MCDB data. So this might raise a question among data users about the representativeness of the remaining population in the MCDB. Fortunately, a recent study conducted by HSCRC using the 2019 MCDB and hospital discharge data found that patient using the hospital services, the case mix index, and the age distribution are similar to the subset of patients found in the MCDB related to the total population of patients observed in hospital discharge data. What this result means is that despite excluding the self-insured ERISA and FEHP plans, the MCDB still represents the larger privately insured population for research and policy making. Next slide, please. So overall, per capita spending across all markets was $5,603 per person in 2019, which is an increase of 2.6% compared to 2018 value. So in comparison, the CMS National Health Expenditure 2019 report showed that among private health insurance per person spending was $6,128, which is an increase of about 5.2% after we exclude Medigap, dental services, and the net cost of private insurance to make apples-to-apple comparison between NHE and MCDB data. So the remainder of the presentation basically describes what does this annual spend mean from the context of market size, different service categories, and the drivers of this increase. Next slide, please. So when we break this data down into individual market type, we see that within each market type, we observed different growth rates. Both large group and individual market showed the growth rate, which was similar to the overall market growth of 2.6%. The small group increased by about 3.2%. And we have known that the growth rate in small employer has been pretty much stable in recent years. Let us now look at the enrollment trend. Next slide, please. In 2019, there were 1.35 million members under 65 years of age enrolled across all markets at the end of December. These members were about 1% less compared to the prior year. Enrollment in small employers showed a decline of 1.7%. So overall, enrollment in the individual market stabilized in 2019. However, enrollment in the on-exchange market increased by about 1.8% in 2019, mainly due to the Maryland reinsurance program's impact enabled by ACA 1332 waiver. And just to have benchmarked these values, we looked at the State Health Access Data Assistance Center, or SHADAC for short, showed that the enrollment among privately insured in Maryland decreased by about 1.2% in 2019. This is an additional validation that the data in MCDB is representative of larger insured population in Maryland. SHADAC also reported that the number of uninsured members decreased by about 0.2% in 2019. This tells us that enrollment changes in privately insured population most likely reflect a shift from private to public insurance. So to summarize, membership enrollment in privately insured population continues to decline or shift. Now, let me turn to show you the illness burden of this study population. Next slide, please. So for this slide, we used Johns Hopkins ACG software version 12 to understand the private insured population risk trend during this analysis period. We used unscaled concurrent risk score and grouped the population into different market segments. The unscaled concurrent risk score helps us to understand what the illness burden among the study population when we compare this to the national reference. So as we can see, for example, if the study population risk score is greater than 1, it indicates that the population is sicker than the national reference population. Overall, the median expenditure risk score increased marginally in 2019 to 1.37 among all markets, after it showed a marginal decrease in 2018. In all 3 years of study, the median expenditure risk score was highest in the individual market, which continues to show an increase from 1.36 in 2017 to 1.43 in 2018 and 1.47 in 2019. The large group market showed a marginal decrease in 2018, but increased again in 2019. The small group market showed a similar pattern as we saw in individual market, with a continuous increase year over year. So in the next slide, I will show you the prevalence of certain chronic conditions that will help us to better understand this trends in illness burden. Next slide, please. So all 3 chronic conditions prevalence showed a marginal increase from 2018 to 2019. Hypertension remains the highest prevalence among the selected chronic conditions at a value of 14.2%, and depression was the lowest prevalence of 7.2% in 2019. So for this report, we focused on diabetes, hypertension, depression prevalence. Diabetes in particular is the Maryland total cost of care model's priority area for improving population health. Hypertension is one of the most common chronic condition in US adults, and its control can help prevent the development of more severe and costly acute care conditions such as heart failure and stroke. Similarly, assisting patients with prediabetes to make essential lifestyle changes can help prevent the onset of type 2 diabetes. And depression can also be costly in terms of increased healthcare costs measured by direct medical expenses as well as comorbidities. And as per one estimate, depression is estimated to impose a total economic burden of $210 billion per year. So in the next slide, we will look closely with the per member spend within each service type category to understand better how this annual spend is broken down. Next slide, please. So to understand the impact of different service types on total spending, we group the claims as inpatient, outpatient, professional services, lab and imaging, and prescription drugs. Our analysis show that except the inpatient category, all other service types spending continued to increase in 2019. In 2019, the inpatient hospital facility spending decreased marginally by 0.1%, which accounted for 15.4% of the relative split of the total privately insured per member spending. Outpatient services spending continued to increase by 4.1%, while professional service spending increased by 3%. These two service types were the primary contributor of the overall 2.6% increase in 2019. Labs and imaging showed an increase of 2.6%. This accounted for about 5% of overall member spending. A prescription drug increased by 2%, which accounted for almost 29% of the relative split of the total spending. Next slide, please. So all this annual spend from a member standpoint, members are really concerned about the out-of-pocket share, because that is what determines the affordability of the healthcare services. In 2019, the overall out-of-pocket spending for medical and pharmacy services was $748 per person, which was roughly about 13% of the total per capita spending. Medical and pharmacy services contributed towards 81% and 91% of the out-of-pocket spending. Within medical out-of-pocket cost spending, it increased by about 1% compared to 2018, and the pharmacy services out-of-pocket spending decreased by 3% compared to 2018. Now, we'll look at the drivers of these annual changes. Next slide, please. This is a very, very important slide of this presentation, which basically brings together all the analysis and gives kind of a one-stop explanation about what is actually driving the 2.6% annual spend with respect to the individual categories. So inpatient facility cost per inpatient day increased from $4,493 to $4,737, which is a 5.4% growth that contributed to the increase in inpatient spending. Cost per inpatient day metric is based on price and intensity of a service. And as per HSERC, the total approved fiscal year global budget revenue rate for the first 6 months of 2019 was 3.33%, and for the second half of the 6 months was 4.04%. So the difference between our calculation and the global budget revenue rate is mainly due to the intensity of services and the inclusion of non-regulated hospital services in our calculation. So likewise, the increase in cost per visit was the main driving factor in the spending growth in the outpatient facility. In case of professional and labs imaging, increase in demand drove the spending growth with the marginal decline in cost per visit. Prescription spending growth was due to increase in both number of prescriptions and cost per prescription. So we'll now look into the primary care spending among the privately insured population. Next slide, please. Primary care spending increased across all markets from $246 in 2017 to $266 in 2018 and $274 in 2019, which is about 3% increase. Primary care alone constituted an average of about 4.9% of all medical and prescription drug spending each year. This result is comparable to the national benchmark percentages calculated by the Millie Bank Memorial Fund. We classified primary care spending based on the methodology that was described in a 2017 Millie Bank Memorial Fund report. When we try to look at this from different age groups, we see that the members with ages 0 to 18 years showed the highest percent of the primary care spending, which was about 13%. So this could be attributed to more primary care services required for brief recurrent illnesses and the preventive care than adults who seek care primarily when there are significant morbidity or risk factors of concern. So after 18 years of age, the percentage of the primary care spending compared to the overall spending declined as the age increased from 5.1% in the 19 to 24 years group to 3.3% in the oldest age group. Next slide, please. Here, we see that the generic drug usage continued to increase and the brand name drugs continued to decline in 2019. So the overall cost per prescription remained flat with slight decrease in generic drugs and increase of about 13%.
I think we've lost Shankar.
Shankar, we can't hear you.
Shankar, check your mic.
Yeah, his audio went out.
It says connecting to audio now.
Yep.
Ken, do you want to step in?
Sure.
If you want to take a 1-minute break, Shankar could call in on his phone. There he is. He's back.
Chairman,
Never mind.
I was just able to join.
Okay.
Sorry.
All right.
Technology is playing games with me. All right. So I think I left off at this slide. So I don't know where I stopped. Maybe we can move on to the next slide. Thank you. Thank you. All right. So in an effort to shed light on drug cost, so what we try to do is, for ease of understanding, we grouped top 25 expensive drugs into high-level therapeutic classification to show how much each drug class contributed towards the overall prescription per capita cost of $1,590 in 2019. As we can see in this chart, it's the biologics, antidiabetes, and antivirals contributed about 34% towards overall per capita drug cost. And the details of these individual drugs within these classes are described in the report. Let us now zoom on prescription drug spending among state employees. Next slide, please. All right. So in an effort to shed light on to increase transparency, MHCC is now tracking the most expensive drugs among private insured state employees. For this analysis, we identified state employees based on their employer federal tax identification number. We excluded state employees enrolled in Kaiser Health Plan and members above 65 years of age. The study population had a median illness burden of 1.50, which was about 13% higher than the overall population. So our analysis showed that the state employees filled about 350,000 scripts, resulting in 111 millions in total drug spending. Anti-diabetes medication made up of 9 out of 25 most expensive drugs within this group. In other words, they made up of 36% of the top 25 expensive medication among state employees. The top 5 most expensive brand drugs among state employees were specialty drugs consisting of biologics such as Humira and Cosentrix, and anti-diabetes medications such as Trulicity, Tresiba, and Januvia. These expensive medication lists were similar to a 2019 report published by IQVIA, which looked at the medicine spending and affordability in the United States to understand the patient cost for medicines. Next slide, please. So to conclude, the key highlight of this presentation is that overall, the per member spending across all markets increased by 2.6% in 2019 compared to a 1.4% growth in 2018. Large group and individual market spending increased by 2.6%, and small group spending increased by 3.2%. Outpatient hospital facility services and professional services were the primary contributors to the overall 2.6% increase in spending for 2019. The illness burden marginally increased from 2018 to 2019 to 1.37 for all markets. Overall, the enrollment as of December 31st of 2019 decreased by 1% among privately insured in Maryland. This change is consistent with the SHAD Act national reporting of Maryland, which showed 1.2% decrease. Primary care alone constituted an average of 4.9% of all medical and prescription drug spending. Before I end, I want to acknowledge all the hard work put in from all the different health plan representatives to submit the data to MCDB, and the SSS staff doing the hard work to ensure that the good quality of data is created, good quality database is created, and all the staff within the division to bring this report to you. With that, we are ready to take your questions. Thank you.
Shankar, that was a fantastic presentation. It's a lot of work. It's always
Thank you,
generates a lot of discussion. I will open the floor to commissioners who are ready to chime in.
Dr. Pollack.
Go ahead, Commissioner Dordan.
I don't want to be a broken record, but I am curious. What happens to this report?
We are legislatively mandated to produce it. This report includes a lot of collated information. We're to learn from it, the legislature's to learn from it, the departments to learn from it, and public health officials are to learn from it. This isn't a report that generates a series of recommendations as you see here. It's a report that generates a series of findings. And we're mandated to produce it, and we are the source of this information. I think for us, it's making sure that the takeaways and the conclusions in the report match the data, and that we're comfortable that that's true. And it's also for us to learn from these reports and understand where we should be advocating for and working toward change in health policy that moves the needles in the right directions.
And I would just add as well, this is Kennedy Stropman. I would just add as well to a couple Commissioner's trip questions is that HSC also uses this report to benchmark their per capita spending that they receive from the MCDB. So this report is a far-reaching report that are used by other stakeholders to kind of benchmark what are the spending in the privately insured is in Maryland. As Shankar had said earlier, that despite we only have about 56% of the market, as far as the private insurance is concerned, but these measures are still applicable and they are still representative of the commercial population. MIA also uses this as well, as a benchmark to see per capita spending, in the private insured market as well. So this is a very important report. Also, the Maryland Health Benefit Exchange uses this report to track the enrollment for the on exchange as well. So yes, it is far-reaching, and the staff have really put a lot of time into it, and it's actually very important information.
One other comment, if I may, there's no disagreement with me with the expertise and everything that goes into the incredible amount of work that this is. And if I'm always searching at what the board's role is in this, and would look to the staff that, first of all, it's a complete report, which obviously it is, but as we as commissioners, should there be something today that we should gain from this or take away, or any recommendation from Ben and his staff as a board member? Should we do something different, or should we encourage something? Or, with a lot of these reports, we just look at them, we say they're excellent, and they always are top quality. But to me, it's always about what's the value added as board member And should I be doing something because of what I just listened to for a period of time? And if there's not, that's fine.
Well, this is Commissioner O'Grady. Can I kick in here a little bit?
Sure.
Yeah, in terms of thinking about this and what the main takeaway here, if you think big picture about what's going on in Maryland and what's going on across the nation, there's a problem that in healthcare, we have spent more than our ability to pay for it. And the effect has been crowding out of wage increases for workers, increasing national debt, everything else. What this shows that the state of Maryland, by coming in at around 2.6%, has basically not spent more money than the state had. That's pretty close to what the growth in the domestic national product was. So it's sort of, we're roughly 2.5% richer than we were last year. And we've spent 2.5% on healthcare in this state that is roughly, we're in sync. We're not crowding out schools and universities. We're not borrowing more than we have the ability to pay back and shoving it onto the next generation. This is the overall global takeaway from this is very positive. And then the follow-up stuff they've done here to see where it comes from so that we stay ahead of that and continue to do that. If it's in prescription drugs, if it's in our individual market, it's that tracking and making sure things don't get out of whack, and that you're, as we all have with our own budgets at home, that we're spending within our means. And that's the good news for me anyway out of this report.
So
yeah, and I just wanted to build on Commissioner O'Grady's comment. I mean, that's exactly what it is. And what it is this serves as an annual checkup. I mean, I just imagine that, we as an individuals, we go to our primary care for an annual checkup and we get back report that all the labs are within normal range. And that's a fantastic news, because what it means is we have done what it needs to stay in that range to be healthy. And this report kind of serves that sometimes no news is good news, which means that we are doing what we are supposed to within our normal range. Yeah.
So a couple of things to add to that. I agree that the 2.6% number looks attractive. I guess the concern I had was not for us, but for the rest of the country, was it really that is that an apples to apples comparison that the 5.2% to our 2.6%, the rest of the country in this market is growing at double the rate?
This is an apples to apples in that when we look at the National Health Expenditures Report, what we did to make it an apples to apples comparison is to take out the net cost of insurance, which includes things like administrative costs, change in reserve, and contributions to reserve, which is profit. And also we took out Medigap and also dental services. So now we are looking at the per capita spend for apples to apples comparison as to what the information that we have in the MCDB for the privately insurance. And yes, I mean, what we're doing here in Maryland, with our all-payer system, even the total cost of care and all of the good work we do in Maryland, we could see that our per capita spend is lower than the national average at 5,600 versus 6,142 or so.
So I just want to interject. I'm not going to be quite as enthusiastic as Ken, but generally in that direction, that the apples to apples, to the extent we can, the construction of the national expenditure surveys, the approach is quite a bit different. So there are going to be some differences that we see. I did think carefully about the 5.2 to 2.6. And I think Ken's characterization and Dr. Pollack's characterization and Dr. O'Grady's characterizations are all on par, that this is good news. What I took away is that the levers that we're pulling, particularly as it relates to hospital inpatient care, where you saw actually utilization go down, but reimbursement level going up is consistent with what we're expecting with a global budget approach to things. We do think that we should see some growth in outpatient services, particularly in the non-hospital arena, and we saw that. So I think those are the model. What the model tells us should happen, happened in 2019. What I worry about is the disease burden continues to grow. Clearly, thinking about the state health integrated health improvements strategy, we're seeing people, at least in the 3 key conditions we focused on, heart conditions, speaking broadly, diabetes and depression, not much change. And CMS is putting fire under the state, to address some of those population health matters that the model is also supposed to focus on. It's not just cost. So it is, I think it is a good message, but there's more to do. And I think Ken and his team highlighted key areas and opportunities that we can work with on our partners at the state's new commission. The Prescription Drug Affordability Board has to deal with drug expenditures in the state employee market. You see the people like that are sitting before you today that are state employees. Geez, we're sicker, and it appears that we're using more prescription drugs. That affects the state budget year in, year out, and there's expectation that through a number of initiatives we need to address on that. And lastly, the artifact for this report, Dr. Jordan, was really something quite different. That when the Healthcare Commission's predecessor commission was formed, we were told to consider setting health spending targets if expenditures were increasing at a rate faster than the overall growth in the economy. And fortunately, for some that was stricken from the statute in 2000, but we can still be assured, at least in this year, that to Dr. O'Grady's point, we don't have to worry about that. Now, there are other states that have implemented state spending targets, Massachusetts being one of those, and I'll be happily share everyone the paper that they recently reduced. But it is the commission's opportunity to come back and say, maybe we ought to reinstate targets. But we do have a data instrument that can be helpful to do that. I think that setting targets is kind of embedded in the total cost of care model anyway, but the commission could certainly advocate for, we ought to set spending targets and really tie it to the state gross domestic product or something plus or minus that spending level to really, tie healthcare spending to something linked directly to overall economic growth. So I think it's good news, but there are warning signs and there's work to do.
Yeah, Commissioner Jordan.
One last comment, and Ben, I appreciate you elevating me to doctor status, but that's a little bit beyond my abilities. But I this last 5 minutes, starting with Mike's comments on, have been extremely beneficial to me as sort of, okay, here was this great report. Where are we? How do we interpret it? What are we going to do about it? What could we do about it? I just find that very, very healthy and useful because it makes it all, to me, makes it all worthwhile that our staff spent this incredible amount, all this detail. But okay, let's take 5 minutes and say, here's what we can do with this. Here's what we can't do with it. Here's what we might suggest to this committee. I found this conversation extremely helpful and give a really life to the report itself. Thank you.
A couple other comments on it. So my question, first of all, the comment, one of the other opportunities that I saw in reviewing this is the market increase in hospital outpatient department procedures being done. And it seems like there's opportunity in there for the private insurers to manage that more tightly, to direct many of those outpatient procedures to non-hospital based locations where we know the cost is substantially less. I hope that will occur with time. And I think the other thing, Ben, you noted that the hospital inpatient costs stayed relatively flat because while the utilization went down, the cost per unit went up an equivalent amount. And as the HSCRC moves toward getting better control of that issue, we should see a progressive decrease in the risk there as well. But the real problem for me, in looking at this whole thing is that this was a 2019 report, and we're going to compare it next year to 2020. And I don't have any idea how we're going to understand how to interpret 2020 in the context of this report and what we do next from here. Shankar, Ken, Ben, thoughts about that equation?
Dr. Pollock, thanks for the question. Later, I think maybe in June or July, we are going to look at the COVID experience as how it compares with this 2020, 2019. We're not going to wait until for another year to actually do that. And what we probably will expect, we will expect to see, especially when we look at telehealth, we will expect to see telehealth really, spike up when the pandemic actually took part in maybe like April and May. You will see that spike, and also you would see the outpatient services actually take a really plummet dip, because as you know, during the pandemic, all of the electric surgeries and all of that things were actually cut off because of the stay home policy as well. So we anticipating, to see a lot of services, actually outpatient services have decreased in 2019, in 2020 compared to 2019. So those are some of the things that we expect, because we have seen other states early showing of their APCD data, and that is what actually they are seeing as far as services are concerned.
Commissioner O'Grady, you took your mute off. You have a comment?
Well, I was just thinking about, although you didn't include me in the list of people you asked to comment on this, the one thing to answer your question, I think what we're going to be looking for is we're going to be looking for the price tag for the pandemic is what we'll see next year. And the thing that'll be interesting, I would agree with Ken in terms of we can hypothesize where these different cost centers will go up or down, et cetera, et cetera. But what may be the most fascinating part is the things we don't expect, that if we don't see big drops in spending on outpatient and we don't see the big kick up. So it's going to be that kind of the bill coming due and thinking about, and then the year after will be, what is the rebound after a pandemic? Do the patterns go back, to the pre-pandemic? Do they look more like 2019, or is it sort of half and half or whatever? So it is that constant tracking, especially in the counterintuitive things, where you really, you could have hypothesized X, Y, and Z, and some of those things just didn't come to bear, and other things you didn't expect to happen did happen. That's why we count these things up, is to see what the actual outcome is, not our best guess.
So Commissioner O'Grady, something counterintuitive. Might we have closed the health disparity gap during this time?
That'd be quite counterintuitive. But it might be things that you don't expect, like we see a drop off in prescription drug spending that we wouldn't have expected. Or we see an increase in it because people didn't want to go see their physicians, so they just kept taking their meds, and if the physician had seen them, they would have cut it out. I don't know what we'll see. That's part of it. I would have, if you asked me hypothesize, I would have told you just what Ken told you. We'd expect to see this drop off in office visits. We'd see this drop off here and there, and we'd see a kick up in telehealth and maybe something else. We know, hypothetically, or at least what we're hearing on an anecdotal basis or hospital by hospital basis, is a drop off in elective surgeries, which all sounds very reasonable to us. Will we actually see that? And then will we see a big explosion of elective, surgeries in the prior year because of the pent up demand for it. I think next year's and the years after is going to be a pretty interesting report.
There's a lot to look at. Just anecdotally coming from our system, I can tell you that the elective surgery piece probably overstated. Most of it, a lot of it, we caught up with in that year, but within that year. But what's interesting is that during the pandemic, there were numbers that suggested that admissions for things like CHF fell off dramatically, and admissions for things like COPD. I mean, these are big ticket items in terms of overall inpatient cost, fell off dramatically as well. And you'd say, why in the world would that happen? Well, it turns out that exacerbations of CHF and mostly COPD, but even CHF, are probably triggered sometimes by minor viral illness. And minor viral illness goes away completely in the context of a pandemic when you are instituting social distancing. So lots of things like that we're going to learn over the course, I think, of the next year or two as to what happened. And that stuff, you don't catch up with that stuff. There's not a pent up demand for viral illness.
Right.
So there's some good side to this as well.
And even in the community side, maybe things that we didn't measure or count, I can tell you for a fact that our collaboration with hospital systems has increased significantly. The receptivity towards something like bringing services into a barbershop and salon is being seen as a positive thing to do, and something that is sustainable and can be built upon. I've not seen this level of receptivity since the decade I've been here.
I would just say that we probably see in 21 and 22, not 2020. But hopefully we will see changes from that type of change in behavior and by 2021, by now. Because I agree with you. I think the outreach efforts from major health systems into our previously underserved communities and challenged communities is much greater than it's ever been. And the effort around that is much greater. And that I see as being sustained going forward.
My only add-on is I'm very interested in not the spending as much, but rather the population health. And unfortunately, we get population health measures from claims. So we're going to have to figure out if we can capture it through clinical data or augmenting claim information, but simply obesity, depression, diabetes. Many people avoided seeing physicians and other providers during the pandemic. And did that have a long-term impact on underlying chronic conditions? I don't know. I think the point that you raised about COPD is an interesting one, and one that is, may have some broader applicability. The American Psychological Association did a survey, and it was surprising in the respondents, over 50% of people said they gained weight during the pandemic, and a sizable percentage, I don't know.
Yeah, the other 50% lied about it?
Yeah, no, the other 20% lost weight, which is plausible too. But I'll share that 2 or 3 page document with everyone. It was kind of surprising what the results showed about the weight gains people reported. Sizable percentage of the population reported 25 pounds or more.
Yeah. So at the risk of, I know we're late, but at the risk of dropping one more bomb at the end of this conversation, the 1% transition from privately insured to public health, to me, in a year like 2019 is worrisome, right? That was a very strong economic year. And we would have hoped that the transition would have been in the other direction, from publicly insured to privately insured. Yet even in a year like that, we saw a transition in a less sustainable direction, I would argue. And I think we need to be careful going into 2020 and 21, because again, anecdotally, it looks horrible in 2020 for that transition from the standpoint of sustainability.
Yeah, I would characterize the 2019 numbers as stable. The the Shattuck numbers, which are based on the American Community Survey, probably are the best. You know, what we're seeing is a snippet of the privately insured market. I wish we had the ERISA and feds included, although I think in 2019 we could safely say that federal employment probably did not grow at all. But our numbers
overall employment numbers in 2019 were amongst the strongest the country's ever seen.
No, I agree, and we probably would be well served if we did have the ERISA data to really gauge that fully. But I mean, so the census in 2019 had the Maryland numbers, I believe, as no change, because of the margin of the standard error around the estimate for the survey. So
yeah, no, I agree with that. I'm just concerned that they didn't get better.
Yeah. I mean, employment doesn't necessarily mean you take up insurance. So, Dr. Pollack, too.
That's the point. Yeah, that's correct. All right. Any other comments before we move to updates or projections for next month's meeting? Ben?
Yeah, thank you very much. I have only 3 items currently that are definitely going to be presented. We will continue with our certificates of ongoing performance for percutaneous coronary interventions. That's the work that Eileen Fleck and her team have been doing. I wouldn't say we're rounding the curve on that, but we're corner on that, but we're getting closer to the the completion of the entire cycle. And then there'll be a fair bit of time spent on data release and data collection regulations, mostly on data release. Over the past, really almost a year now, Ken's team, along with a work group that included Dr. O'Grady, have been working on modernizing our data release regulations that would cover the medical care database, but really has been organized to cover other sensitive data that the Commission collects as well that could be released under this same framework. And so we will present that for the Commission to consider for for action on proposed regulations. And it's an important step in appropriately sharing this information as we move forward with also capturing the data on a more timely basis.
Thank you, Ben. Thank you, staff, for a great meeting. I'll accept the motion to adjourn.
So moved.
Commissioner Boyer, second.
Second.
Commissioner Boyle. Any opposed? Hearing none. Thanks, everyone.
Thank you. Have a good month.
Thank you.